As a pivotal aspect to any effort to improve health and patient experience, the pillars of which this very event is taking place. Would you please tell us your name, your organization, a brief description of your language access team, like composition, where it fits in the organizational chart, and things of that type, and then 2 to 3 major initiatives that have made a big impact in the health and experience of families who communicate in languages other than English or who have special communication needs. And can we please start with Mr. Torres?
My name is Ricardo Torres, and I am manager over the Language Access Services Program at Cincinnati Children's Hospital. The Language Access Program in my hospital is about 8 years old. Started out with maybe 4 or 5 individuals, a supervisor, about 4 interpreters. 7 years later, now we are a team of 23 full-time employees total. Specifically, we have one supervisor who is responsible for 3 scheduling coordinators, 1 full-time translations coordinator, and right now basically we cover our daily need, language access services need, with 3 full-time contractors and 20 full-time staff interpreters, which basically is a combination of 7 Spanish, 7 Arabic, 1 sign language interpreter, and the remaining individuals, believe it or not, are Arabic interpreters. So we're very busy. We handle between 200 and 250 appointments on a daily basis, and that's actually pre-scheduled appointments. Usually at the end of the day, we have to add about 25% to that number, considering the fact that there's a lot of appointments that obviously are unscheduled. So the emergency department, for example, and the multiple clinics that have walk-in visits. So we have to account for that number as well. So in order to meet that demand, we have a 7-20-10 coverage model, which means that the majority of the appointments are covered with face-to-face on-site interpreter. That's 70% of our need. 20% of that, and it's covered with video remote interpreting, and then the remaining 10% is actually OPI. So that's how we get around to cover all that crazy demand for services. We have a 5-skill level system that is actually matched with a 5 visit type system, which means that all of our visits are actually divided by complexity levels. And based on those levels, we allocate a particular interpreter that gets to cover those appointments. So we have level 5 appointments, so to speak, being covered by level 5 interpreters, and so forth and so on. And that's something that we created in order to make sure that the particular visit and the nature of the visit matched the qualifications of the interpreter. We specifically, regarding the 2 major initiatives, I'll talk about 2, not 3, 2 major initiatives that we have developed. I can tell you about something that I'm actually very proud of, which is the automated satisfaction surveys, telephonic surveys that go out to our LEP community on a daily basis. So we have developed a relationship with a vendor which basically receives a data file package on a daily basis from Epic, and makes automated calls to all the patients that have had or have received, based on how is marked in the system, linguistic access service or language access services. So the call goes out, and then they call the patient as a machine, basically. It's very similar to what happens when you get a call and you're asked to confirm your appointment with the doctor, and you're asked to press 1 for yes or reschedule or cancel. Same thing. This recording obviously is delivered in language. We only have it in Spanish and Arabic, and the non-English speaking person is able to then just followed the prompts and answered 5 specific questions. They basically asked if they had an interpreter, what did they think about the visit, would they like to report some type of concern they had about the visit, and overall to rate their satisfaction about the language access service they received. So that's something that we have had for about a year or so. I'm very happy with the results because it has connected our patients with the program that we run. This hardly ever happens. You have, all this activity covering services, but you hardly ever get to hear from the patients regarding what they think about the service you provide. So this has been very, very meaningful to us. And then the second initiative, specifically, it's around the provision of video remote interpreting services. So VRI, as you know, is here to stay. And about 2.5 years ago, we decided to implement a system that wasn't necessarily new to the industry, although quite familiar to the West Coast. And basically, it's about making sure that our interpreters get to be part of a video remote rotation. So out of the 20 interpreters that we have, everyone gets to be part of video duty, so to speak. We have about 35 video remote interpreting units distributed throughout the hospital, and then whenever those those client providers, need services, the particular language that they need, and in this case Spanish or Arabic, if our interpreters are available, the calls go to our interpreters so that they can take care of it. If our interpreters happen to be unavailable, then the call goes out to a network that we're part of in order to make sure that they get someone. So that's something that we've been implementing. So far we have 4 remote interpreting stations, and our interpreters cover different shifts, including third shift. So we have 24/7 coverage in the emergency department, and whenever those ER interpreters or station interpreters in the ED have downtime, they're expected to go on and log in and provide services. At that time, probably there's not going to be a whole lot of activity inside the hospital, but clearly for all the hospitals they also need the service. So that way we maximize our resources, and at the end of the month we actually get credits on our bill. That obviously make a lot of people very happy. So that's basically one of the other initiatives that we have implementing. It's, believe it or not, even though we have been running it for 2.5 years, it's still in its infancy. There is still a lot to do in terms of deploying more units and making sure the clinics and inpatient floors actually accept VRI. But I think we are on a good path, and that's basically what we've accomplished.
Good morning, everyone. Can you hear me? My name is Valerie Huang. I am Program Manager for Nationwide Children's Hospital. If we can start with the structure of our department. Our department is a part of clinical services. It's under a big umbrella of patient care services. I report to social work and language access services, and this is to give you a signal that our hospital actually value the services that provide our limited English supervision family. We incorporate with all the services that provide comprehensive services. I will dive into detail when I mention the initiative later. In terms of structure for our department, we have 2 full-time schedulers cover from 6:30 to 5, and then in addition to that, we have a 24/7 on-site Spanish interpreter coverage. This is very unusual for a lot of hospitals because we do value the face-to-face coverage for our family, and you will not believe that in the middle of the night, 3 a.m., you have a family member walk into an emergency room and they see an interpreter there, speak their language, agree with them, and it's just a sense of release. So we receive a very support from our administration that will continue our 24/7 coverage for our family, especially emergency room and emergency room urgent care. For our staff interpreter, I have 25 staff. Their language composition is Spanish, Somali, Arabic, and then French. Again, we will try not to limit the access to our family's care in terms of scheduling system. So at a given time, we do not limit their schedule time. So a lot of time we run into a challenge of we may have 20 appointments that need Spanish with given hours. So we have no choice but to utilize a lot of agency interpreters. So this is another initiative. We'll try to look into that, try to model some other hospital, try to utilize our staff in more mobility level. Our two full-time schedulers that they unfortunately do not speak English, but they have equipped very basic reading skill. A lot of time we will receive some language phone calls that require interpreter. We have a new services just launched 2 years ago that is direct dial services for our family. We recognize that the needs for our family to immediately access to an interpreter instead of have our provider try to figure out what language they speak. We have 18 different language launch for our family. They're able to contact to an interpreter before they even talk to one of our providers within our hospital. So that's again a proof that a hospital actually really take into the consideration that we want to provide the best patient experience. One of the initiatives that we launched actually has been going on, but we continue to contribute as a language access champion and then language service provider team. It's patient family centered care. We actually promoted healthcare home, that we provide interpreters for home care, we provide interpreters for home visit, and we recently have a new program that collaborate with communities as well as school district. So our nurses and the interpreter will actually visit the school and then work with our kids that at school. So that will save a lot of time for our family to struggle with their schedule and then bring their child to our hospital to receive care. So this is a patient family center initiative. So when we talk about patient care center, we look into the basic infrastructure, which means that we want to make sure all the providers who provide care to our families that are cultural competent. So interpreter services staff work very close. We have very good collaborative relations with our providers. We have very open dialogue in terms of how we can provide better services. Each individual interpreter, especially staff interpreter, we open their scope of services by not just facilitate the interpreting services. They are there to be the cultural brokers. They help family, they help them navigate the system. Not even navigate the system within Nationwide Children's, even navigate the system within the community. And you will often see our staff interpreter running in the building, not just stick with their appointment, they follow family to get social worker to help them, and then follow them to pharmacy, and then follow them to get financial aid application. So our interpreter has been open the scope of services, and then we also found out that also increased their job satisfaction level because they feel they're empowered to help family. And another initiative is also part of infrastructure. Everyone matters. We value a diverse workforce, and then so we are in the process of bringing more bilingual staff that we can provide better services. But again, we try to emphasize that, again, this is not to replace interpreter, because in a pediatric setting, especially that it's a team healthcare setting, even though one particular provider speaks patient's language, doesn't mean that his family does not need an interpreter, because family need language assistance in each point of care. So it's very important that when they work in the hospital, they feel welcome, they feel that their language need has been met. Next initiative that we have been actually still ongoing is health literacy initiative. We all talk about health literacy. This covers broad scope, even for English-speaking patient and family. However, we particularly look into family who was limited English proficiency. So everybody probably familiar with EPIC. or other system. That Joint Commission definitely require that we need to document patients' preferred language. But we often forget that patients prefer language in written form. So during the year of 2014 and 2015, we have initiated health literacy, initiated that. We continue to translate a lot of patient education document. We make sure all the patient education information that we give it to our family is in their languages. Even though at the time of discharge, the translation is not ready, we will mail to the patient's home as a follow-up. So the year of 2015, we did about 350 translations, just as single as patient education. We even dive into translation of all the after visit summaries. And it could be tailored with individual needs for each family. So that kind of gives a nutshell of how interpreter services in Nationwide Children has transformed from, like Ricardo said, that we start with only one coordinator who is bilingual, and then we have a couple of staff who work in primary care that happen to be bilingual, and then we have a team of 4, and now we have a team of 28 plus 2 scheduler, including myself. So with that, thank you so much for listening, and then it's good to hear to share experience with any champions.
My name is Diana Gueits. I am the Director for Diversity and Inclusion at Cleveland Clinic. So I do not manage a language access team or a team of interpreters. So I'm on the other side of the health equity, the health literacy, the cultural competence, the population health strategies our system has, and really aligning and working collaboratively with our Global Patient Services, which is a group that really does the language access and interpretation for our system. So just to give you a little bit in terms of the landscape before I go into the structure of our interpreter staff at Cleveland Clinic. At Cleveland Clinic Main Hospital, just in 2015, we saw about 6.62 million outpatient visits. It gives you a scope for the number and the scope of our building. Our building, there's about 42 buildings on 165 acres of land. And that does not include the 150 outpatient settings that we have throughout Northeast Ohio. It doesn't include the 11 hospitals and the hospitals that are located at Weston, Florida, Las Vegas, Canada, Abu Dhabi, and soon to be London. And the Global Patient Services division is enterprise-wide, so they cover the services for all of that. But at main campus, we have about a staff of 40 individuals, 21 of them speaking Arabic, 10 speaking Spanish, and 9 multilingual. But with the complexity of a large system that we have and the amount of patients that we see, we also utilize vendors. So we utilize Pacific interpreters, so the language line you all are probably very familiar with. We also make sure that we look for local minority-owned, women-owned as part of the supplier diversity commitment that we have with our organization. So we work with VocaLink, Lisa, little shout out, little ad from Lisa's organization. And then we utilize TransPerfect and InterChez for some translations of documents. Now within Global Patient Services, they handle international and domestic patients. And they do the interpreters, the on-site interpretation at main campus, as well as the translation of documents. They support some of our international medical operations work, as well as working with our international medical education staff. So that kind of gives you an overview of some of the work that's done at Cleveland Clinic. And did I mention that the GPS department has been in existence for over 40 years. So they were established in 1976. And when you think of when class standards came into play in 2000, we were kind of ahead of the ball curve. But we still have a lot of work to do. I always think that healthcare is about 10 years behind everybody else in terms of that realm. So 2 to 3 major initiatives that we've worked on. Certainly, probably the thing that I still find surprising when I meet with other individuals from other healthcare systems is several years ago, we made sure that our administrative policy really codified standard operating procedures for the role of an interpreter, for our language interpreter as well as our deaf interpreters. And when we did that, we also rolled out enterprise-wide training throughout the system to make sure that everyone understood where this policy lived and that they were accountable to meeting that. And then we outlined all of the regulations, regulatory agencies and accreditation bodies that we needed to adhere for in terms of compliance. So they need to understand the compliance component of this, that this was just not concierge services, even though we do provide those as well, because through Global Patient Services, they kind of do one-stop shopping, particularly with our domestic patients. So they follow them from the point of scheduling their airplane ticket to come see us, all the way to the point that they leave back home and beyond that. So it really is kind of patient navigation 2.0 at Cleveland Clinic in terms of interpreter services. The second thing that we started to do is around real data. So race, ethnicity, and language collection efforts, and how we all had to kind of, as a healthcare systems, really start collecting those data based on some mandates that came through the HARQ, and looking at that. And so a lot of hospitals went and made sure that their EPIC systems or whatever systems that they were in, that they were collecting the data, but really then taking it a step further and leveraging the data as a meaningful use data. So we were able to identify, not only through the reporting that we get from our interpreter services and our vendors in terms of the utilization and the time that's spent interpreting, but really looking at where were the points of access within our system where we were seeing patients with limited English proficient needs that may have not been going through the interpretation services. And also identifying communities that were maybe coming into the system, so really doing trending reporting based on those demographics to make sure that we needed to align whatever we need to do in terms of service lines and FTEs, and making sure that from a workforce component that we started to recruit bilingual, bicultural providers to really meet that growing patient need. So that's one area that we still continue to do a lot of work in, but leveraging the race, ethnicity, and language data. And then something else that may have, probably is not in the realm of what normally happens in the scope of work, is we have a Hispanic Employee Resource Group, right, Salud. And Salud, we have a men's minority health event at the main campus that brings about 3,000 men once a year for this massive health. And a couple years ago we decided, and it was really targeting the African American community, which is about 50% of the population in Cleveland, Ohio. And so we decided we wanted to also open that opportunity to the Latino community at Cleveland, which is the second largest community there as well. And so we engaged the Salud members into the men's minority health, and we did brochures and advertising in the Latino community. And then we said, okay, we have about 3,000 men that show up at this event. How are we going to stand out? So we developed these buttons that say, Yo hablo español, right? And so all the Salud members had those buttons so they would be immediately visible to patients who were coming in for this one-time health fair, right? So what happened out of that health fair is certainly we got, patients would identify, hablo español, and they would go straight to them and we would navigate them through whatever part of the health fair that they were interested in attending. But what happened is we identified that was an opportunity for engagement. It impacted the engagement scores of those caregivers who spoke a second language, but weren't in the role of an interpreter. It now has transitioned to, so not only is it an engagement opportunity, it's something that we use in health fairs where we're able to call out, the interpreters wear them on their, they have the little buttons, the holders that are employee badge at one, to transition, kind of the Disney badge. Have you seen the Disney badges? So kind of following that model of Disney to make sure that somewhere on our badge, the languages that are spoken are identified. So we're more visible to our patients. And then that has even now transitioned to the point of looking at when we're doing bilingual job fairs for bilingual talent, that is now a branded signature program for the enterprise. In addition to that, we want to complement the other side of the services that are done through interpreter services. So one area that I manage directly is language enrichment for the enterprise. And the disclaimer that I get up and say for every language enrichment program, so we offer 4 different types of classes. The first one is Spanish for healthcare professionals. We offer basic conversational Arabic. We do English as a second language that focuses on American idioms. And then we do accent modification for our non-native English-speaking providers. But for both of the foreign languages that we provide, the disclaimer is this is a program that has been developed to impact the patient experience and patient satisfaction, but it should never replace the skill set of a medically qualified interpreter. And we go on to really provide some case studies before the class so they really get it in terms of the risk compliance issues that we may face if we don't adhere to that. And those classes have been received very well, and we've seen patient experience, patient engagement, employee engagement increase with the offering of that, because it's just not about the interpretation side, it's the cultural competence, the cultural agility, the health equity component on the other side. And when we bring those two together, then you really do have a significant patient satisfaction, I would say, impact, I think it's the value proposition that you have to your patients. That's what you want to offer.
Okay, great. First of all, before I even say anything about myself, I have to say that I wanted to participate on this panel for purely selfish reasons. In order to be able to hear these individuals talk about their amazing programs, I have taken already tons of notes on great ideas that I want to go back and share at my organization. So I feel like we are the infant and the baby of this group, but I will share what we're doing as well. So I'm Cara Martinez. I am System Manager of Language and Cultural Services for Kentucky One Health. Kentucky One Health is based out of Louisville, Kentucky, but it spans the entire state. We are the largest healthcare system in the state. We even have a few locations in southern Indiana. We really are an infant in terms of a healthcare system. We have only been together as a system for about 4.5 to 5 years. And we are really the epitome, I always say, of a really bad joke, because we were the result of a merger between a Catholic, a Jewish, and an academic medical center. Is that right? A Catholic, a Jew, and a professor walk into a bar. And really it feels like a joke some days, as we are really trying to just figure out our place and who we are and our identity. And in the midst of all of that, we're also trying to build a system and care for patients on a daily basis. And so I actually originally was at the Level 1 Trauma Center, the academic medical center that became part of Kentucky One, and this opportunity presented itself, and we have been a centralized department now for language services for the entire state for close to 3 years. So still very much in our infancy, as I mentioned. We serve over 200 locations. I do not know the exact number because literally it changes day by day. We are a health system that is part of the national CHI, or Catholic Health Initiative system. They are based in Denver, Colorado, but manage multiple health systems across the country. We serve, like I mentioned, we have really 2 markets that we serve. We have the Louisville-based market, which is the largest part of our system, and then we have what we call the Central Eastern market, and that's literally everything else in the state. The second largest city in Kentucky is Lexington, so we have a lot of services there. We even serve now a hospital system that is 4 hours away from where my office is based, so very much spread out and trying to determine how we can better serve those patients in those areas. To be able to give you an idea of who we're serving, our top languages as of the last fiscal year, other than English obviously, were Spanish, Arabic, Nepali, Somali, and American Sign Language. I was actually talking to some colleagues last night, and it's very similar to the groups that are served here in Columbus, just I think in a little bit different order. And the first time we were able to pull real data on who we were serving, and as accurate as the data as we've been able to since we came together, we found that we were providing services for close to 50,000 appointments. That was from the end of fiscal year 15, and I anticipate that number to increase at least by a third by the end of this fiscal year, which we're actually, my staff are hating me right now because it's data time and they're having to send me all of their information on who we've been serving. And that is a total of face-to-face over the phone, and we are just getting into the arena of video remote interpreting. So I think our model's probably pretty close to the breakdown of Ricardo's as we're serving a majority of our services are face-to-face. And then I would say it was OPI and then BRI last. We currently have a very lean staff. I manage 10 individuals. 5 of those individuals are what we call language services supervisors or coordinators, and they are based at one of our large hospitals, and they manage a number of different facilities. So they each manage a hospital or two, some clinic areas, some outpatient areas, ambulatory centers. So a little bit, we've broken it down based on really what the need is, and trying to make sure that everybody is kind of managing the same amount of need across the state. In addition to that, we have 5 PRN staff interpreters, and that just means that they work as needed. One of those is Spanish, and she basically works full-time because there's that much need and more. And the other 4 are American Sign Language. So one of the things that we're definitely looking at over the next few years is kind of fleshing out how we can grow our department. We utilize a large number of contracted interpreters currently, and because we have such a variability of our languages, that's definitely something that we will continue to do. In terms of organizational makeup, we, for the past 3 years until April this year, had lived under patient experience for the organization. And in January this year, our system created a diversity and inclusion department. They hired a system VP of diversity and inclusion. We are actually the only CHI entity to have that particular position at that level, so a really interesting time for us. And in April, our services were moved under that reporting structure. So I now currently report directly to the System VP of Diversity and Inclusion. And my staff all the time that I feel like I've gotten a new job without getting a new job, because I'm really in the process of trying to figure out, what this person who now is over our services, who doesn't know a lot about the history of our organization, and so a lot of my time has been spent just trying to educate them and figure out, where we are. On the other hand, it's a super exciting time because we have so much opportunity. He has a passion for language services, and definitely knows that we could do so much with our program. So very exciting time, very busy time, but I think when are we not busy in the world of language services? I will say that proudly that I think we do have the most comprehensive language services program in the state of Kentucky. We are the largest department of any other healthcare system, and hopefully we'll continue that growth. And I think our goal over the next few years is really to become a provider of choice for individuals who are limited English proficient and deaf and hard of hearing. The reason I think I mentioned earlier that I think our services will definitely have increased when we look at our final data for this year, partly because of staff education, right? So we're continuing just the ongoing process, and I tell my staff all the time that staff education will never end. You just need to make peace with it now. We will always have to do it. Just the world of healthcare and the world of any really organization is just the turnover and the fact that we'll always have new faces. I think the challenge with our work, with staff, clinical staff in particular, is that with the exception of a couple of locations, our staff are not dealing with LEP and deaf, hard of hearing patients on a daily basis. And so it's not the same as what they know how to do with any patient that they're caring for. It's an added skill set. And so we have a lot of one-to-one education. When we have a particular unit or a nurse who's never worked with a patient who's LEP before, they don't know what to do. They don't know what resources are available. So So that's a constant struggle for us to make sure that we have that information out there, that it's accessible, and that staff know what they need to know when they need to know it. So a couple of the initiatives that we have been able to focus on in our short period of time that we've been together. The first one I wanted to mention is a bilingual staff medical interpretation qualification program. And this was actually something that I personally had on my 5 to 10 year plan when I started this. But we fell into some grant money and an opportunity to actually train some of our staff. We actually have an internal 40-hour Bridging the Gap training that we open up. It's a voluntary program for bilingual staff. We highly encourage staff to participate. We offer it to them at no cost, which, as you all know, it's not an inexpensive training. The reason we wanted to make sure that we address this in our organization is because of the fact that we know that bilingual staff are used to interpret. No matter what you say, no matter what you tell them, we know that they are going to be put into a position where they may need to or may feel compelled to interpret based on patient needs. And so we have, to date, we have had the program in place about 1.5 years. It's a series of qualifications for an employee to be able to actually take part in the program. First of all, they have to review a policy and sign an acknowledgement before, making sure that their manager knows, what their responsibilities and their role is going to be. The way that we have the program structured is that the bilingual staff are actually really just to be used primarily in their main work area, right? So it eliminates some of the issues that occur when staff are pulled from areas. So if there's a need, if they work on Unit 3A and there's a need on 3A, then they are welcome to serve as the interpreter once they've gone through the entire program. There are some positions that are a little bit more flexible that can, float around. We have some phlebotomists and some patient care sitters and that sort of thing that can float around and serve as needed. The second thing they have to do is pass a language proficiency assessment. They have to do that. We contract with a third-party vendor, and they have to do that for both English and their target language. What we found is that testing the target language, which many times is their non-English language, right, is not enough. We have individuals who, for their work, maybe don't need to speak a higher level of fluency of English. And so we have had individuals who have not passed those assessments. And we also know that we have individuals who think they may be fluent, kind of like when I moved to Mexico right after college and I thought I was fluent and cried the first 2 days because I didn't know what was going on. And so just to be able to make sure that individuals really are meeting that the same level of any other individual that's coming into our facility to interpret. And then the last piece of that is the 40-hour training. Well, I say the last piece, it's really not the last piece. The last piece of that kind of initial qualification is the 40-hour training. Once they go through that program, they actually receive a badge. We have badge hang tags for all of our staff interpreters, all of our contracted interpreters, and now all of our bilingual staff that say interpreter. We have an interpreter symbol. So that's going to help staff identify that that person has gone through our program and they are indeed qualified to interpret in our system. What we're now currently working on, because the program is so new, is kind of the continuation of the program. So offering them some continuing education, making sure that we're setting up workshops for them to be able to kind of ask their burning questions. We also do a quarterly survey, so I send out a survey monthly, quarterly to all the individuals who have been trained. And to date, we have trained a little bit over 40 of our staff. And so they fill that out, and that kind of gives us an idea of how often they're being used. It lets us know their burning questions, anything that they're having issues with that we can potentially help with at that period of time. The other cool thing is we have also been able to open this training out up to the community. So if we don't have enough bilingual staff to fill up a class, we can also open it up to community members. And so again, that's our way to be able to help grow the interpreter community. So we have a lot of individuals who are interested in becoming interpreters and don't really know where to start. And so our organization is kind of as an extension being able to kind of get them started on that path, which in turn obviously helps us because we do utilize so much contracted interpreters. The second thing I wanted to mention is our language services rounding. So this is something that we've done pretty much since the inception of our system-wide department. And we actually ask all inpatients in our hospital facilities about 10 questions. And we do this for a lot of different reasons. First of all, we want to make sure that the information that was collected at registration is correct. So, we ask them basic things like their name and their preferred language. We also do it to make sure that services have been provided during the length of their stay, that appropriate services have been provided, that we are indeed providing the services in their preferred language. For those who are limited English, we want to make sure that a phone is in the room for any needs when a face-to-face interpreter is not available. And then we also just want to make sure that patients are satisfied and that they have what they need from their nurse and that there hasn't been any issues that we can help address. What we do with that information is kind of the third point that I wanted to mention, and that is our initiative to tie everything back into the quality of the services that we're providing as a system. That's something that all of these individuals have already talked about somewhat. So my staff actually take that information, and if they find, for example, that a patient has been incorrectly registered with a preferred language, so maybe they are, this is very common, maybe their preferred mode of communication is American Sign Language and they've been registered as English. And we actually go into our safety reporting system and we put in a safety report. And so that safety report goes back to the department where the error occurred, and they have to do education and report back, and it's a constant tracking of trends. The other thing that we look at very specifically is whether or not interpreter usage has been documented, and we are currently just focusing on consent forms. And so once my staff do a round, they actually go and look in the patient chart if the patient has been consented for anything, and all patients have been at least consented to be treated, right? And if interpreter documentation is not on those forms, that also goes in as a safety report. So those are really the two main issues that we have. Those are also specific goals for myself and for my staff. And so, for when we're talking about performance evaluations and we're talking about meeting specific goals for the organization and where we want to make a movement and a mark, that's what we're looking at. We look at that monthly and then we tally that up at the end of the year. Moving forward, under our new diversity and inclusion alignment, those goals will also be goals that my system VP will also own. And so, his role is really going to be to escalate that with the physicians, leaders, the nursing leaders, because as you all know, those are really our two main areas of where we can make an impact in making sure that services are appropriately utilized.
Valverde, Associate Director of Interpreter Services and Destination Medicine. So I'm really honored to be here with the panelists next to me. I've already learned things. I've been really writing down some good notes about things that hopefully we can reconnect with. For example, I was really impressed with the Epic customized calls for LAP patients, so Ricardo will be picking your brain about that. The home care, home model, visiting schools with providers and interpreters, so Valerie, expect a call. Definitely want to touch base with you on that. The GPS program at Cleveland Clinic, come on, you guys are really the best when it comes to patient care. The international program, I've learned a lot already from you as well. And then Cara, you say you're brand new to this. You're already a step ahead from us, especially with the voluntary bilingual staff program. We've started to pilot that, and we have actually one person, Catherine, who is a nurse in our ED, and she is the first one to help us pilot this program. So I'm glad that she's here participating, but I will definitely ask you lots of questions about your incredible program there. All right, so a little bit about us in our hospital. So we are a level 1 trauma center. We have 8 hospitals in total. We have about 2,200 beds. We're quite a large health system. We're adding one more hospital soon that will probably add close to 100 beds in the fall. So we keep expanding. We have a team of 20 interpreters. 10 of them are full-time, 10 of them are part-time, and then we have what we call a virtual team of interpreters, providers who are champions to our program, who really support our policies, and we're just really thrilled that we have so much support in what we do. So I'm going to go right into some of our initiatives in the hospital. I know we're running a little bit low on time, so I want to make sure I talk about that. Before I do that, though, patient experience is where we live. We're housed in patient experience. We meet, though, every month with our safety and quality officer, who is our physician champion, and just really keeps us aligned with the clinical teams. So if we have to have some tough conversations with providers as far as, shifting resources or assigning one way or another, she comes to the table and really helps to partner with us in having some of those conversations to get more buy-in. I don't want to pretend that I'm a clinician and, know the dynamics of patient care. So bringing her to the table really helps to negotiate and having those balanced conversations that are really important to our providers to understand both sides of the equation to provide the best patient care. So some of our initiatives that we've done on an organizational level, we have developed an international patient program. Of course, Cleveland Clinic to my right here, definitely not as large. But we have decided as an organization to team up to partner interpreter services with Destination Medicine. We feel that we are a team and we are stronger together. There's a lot of overlap and dynamic that happened with patient care and treating and caring for international patients who don't speak English or who are deaf. So our interpreters become interpreter coordinators. So they do some of the patient navigation that we need help with. It becomes a dual role. We do have some clear boundaries to that role because we want to make sure we respect and also are integral and really follow the integrity of the interpreter role. But certainly there's some opportunity for enriched patient experience. Anyone who comes to work at our medical center, as we're signing our contracts, we're agreeing to improving the patient experience for all of our patients, no matter what position you have in our medical center. And that obviously includes our interpreters. So that's sort of the added value that our interpreter team brings to our international patient program. And we work very closely and very well together. So organizationally, that's one big impact that we've had. Another great initiative that we've been working as organizational wide, and I would even say not just the medical center, but our whole university, is a new impact grant that we have. And actually Dr. Martinez is here in the audience, and I know he's going to be talking about his research later on. But what it is really bringing and investing in our new generations. So at the level of high school and new entry into college, we're developing a program to promote and create the new professionals in interpreting and medical interpreting. So we have a track from the junior and senior year in high school to be interested in interpreting, and we do provide them as sort of the gateway or sort of the capstone end. We put them through the 40-hour Virginia Gap training, and we also provide them a shadowing opportunity with our interpreters, an internship opportunity, and hopefully we can follow them through to get certification and be involved in health sciences into their future careers. So we're really trying to promote at the entry level so that we can have better qualified and more robust professionals in our industry. So that's at an organizational level. When it comes to staff training, I would say that one of the pillars, and I think something that is unique to our organization is, and I'm just really incredibly proud that we have this, is every 2 weeks we have new employees joining our organization. It could be anywhere between 30 to 100 people. It's every 2 weeks. We interpreter services have 30 to 40 minutes dedicated to talking about our services, our resources, our policies, answering questions to new staff joining our organization. It's not just a handout, it's an actual class, a 30 to 40 minute interactive class that we offer to make sure that people know that we're here, we're present, we have resources available to our patients, and we want to make this information easy to access for our staff. The Joint Commission recently came to visit, and they thought that was the best practice that we have, in our organization. They had asked several staff, how nurses, social workers, other disciplines, physicians, how would you access an interpreter? And they were amazed at how quickly and easily staff knew how to access interpreters at any time of the day or night. So we're really proud to have that process in place. The other thing that we do is we provide cultural awareness classes. We have 5 of them that we provide every quarter. And all of them have CEUs for nursing and social work. We want to make sure they're engaged in providing the service and also partnering with us to make sure we provide the right resources and information to our LEP and deaf patients. Those 5 classes that we have are the refugee's journey, basic communication needs of the deaf patient, caring for our Hispanic Latino patients, survivors of torture and trauma, and understanding our Muslim patient population. They're very well attended, and the unique thing about that, besides the content, which is amazing to have experts come to us and talk to our staff about these wonderful topics, is we also get an extra 10 to 15 minutes because we are hosting it, we are sponsoring it, Interpreter Services, so that we reiterate the services that we have, the resources that we have, and we put a face to our department constantly. There are 5 classes and they're offered every quarter. So it's really become a staple to our department and a really wonderful way to continue engaging with staff in many different ways. The other thing we do is partnering with our individual clinics. We do what are called walkthroughs. So we have our new Interpreter Services Operations Manager. She's not here on 2. She's been a wonderful addition to our team. Her, as well as with other team members, they walk through each individual unit throughout the year, and we want to make sure that we understand their patient process, their patient flow. And then we talk to them about how can we incorporate our resource to your patient flow. It's really become a win-win because obviously we can tell them, you know, this is how you use video, this is how you contact phone, this is how you contact on-site, and just kind of leave the information there and that's it. But we need to understand their side of patient care. We need to understand how that flows. And sometimes video is just not going to work in that process. Okay, so then we identify those areas as, well, for those areas we really need to provide on-site. In some areas, video and phone are perfectly fine. So then we engage with them and we negotiate. We say, okay, you know, it looks like your patient flow, these are some good opportunities to use phone, to use video. If you get to this point, you might want to engage with on-site. So we try to negotiate, have good conversations and partner with them to make sure that they are also involved in what resource is most important and needed, most appropriate for their patients. Okay, that's been a really good success with us. The other thing is, as we understand, and Ricardo also mentioned, video is here to stay, and we believe that's the truth. I mean, technology is obviously advancing, and I try to shift the conversation from, I need a live interpreter, to, I need a resource, right? Because the video interpreter is also live, right? And breathing, I hope.
As long as they plug it in.
Yeah, exactly. So, you know, with that being said, we want to make sure that, you know, whatever resources needed is available to our providers. And actually, I just lost my train of thought as I was joking about that. But, oh yes, so because video is here to stay, because phone is also here to stay, and it is going to grow, we have one person in our team who has dedicated all of her time to troubleshoot and to do training and deployments for video, and as well as for phone. We used to have our operational staff running crazy, you know, going from the call to scheduling to doing this and to doing that, and it seemed very disruptive, and it was getting to a point where, because we're growing so much with these resources, we really needed to dedicate a person. That person is sort of the face to the resource, can really do a lot of quick in-services with our staff, check on the units to make sure it's plugged in, make sure it's working properly. She touches all of our health system at least once a month, goes to the different areas, and it really helps to help that support that our providers need. Yes, we do have resistance with some providers. I think it's always going to happen. Technology sometimes can be a little bit scary and can be challenging, but as long as you continue to partner and reiterate, with your providers, I think it can be a good outcome. We definitely have, good outcomes with that. I know we're running out of time. Just a couple of other quick things. As an organization, we have really committed to having high standards with our interpreters. With our department, with our organization, we support certification by paying our interpreters for the certification. It doesn't matter what certifying body it is. We will support both of them, but we will not only provide that support for training, as well as pay for certification, because we want to make sure all of our interpreters are certified. But most importantly, we want our patients to have the best quality care and service, as well as with our providers. So I do think that's extremely important. And in that, we want to also provide very consistent service to our providers. Too often we hear from hospitals, including us. I mean, I don't mean to say that it doesn't happen in our organization, but often we hear from providers saying, well, that interpreter did it for me, or, that certain person did it differently, or whatever it is. So we want to make sure we're consistent with the way that we deliver our service. So we have what is called ground rounds during our quarterly meetings. We try to take at least one case study. We analyze it just like clinicians would. They debrief on a case, and then we come up with a solution that's consistent for all of us when we have these situations. So that really helps in building, because I think, part of I think leveraging and really raising our standard is to utilize some of the techniques and strategies that our clinicians use, so that we could also be part of that healthcare team and mentality. And healthcare providers will certainly not only support that, but see us as a partner in our healthcare to our patients. I know we've run out of time, so sorry. Thank you for your time. I really appreciate you.